afternoon, everybody. On behalf of Transfusion Medicine Academic Society, I welcome you all to today's webinar, Standards for Blood Transfusion Information, an Introduction to ISBT 128. Before starting the session, I request all the participants to kindly keep their mics muted. For chairing the session, today we are privileged to have with us Dr. Ganesh Mohan sir, who is the Professor and Head Department of Immunohematology and Blood Transfusion, Kasturba Medical College, Manipal. Without any further delay, I hand over the session to you, sir.
Thank you, Dr. Shovik. Could you please change the slide? Next slide. Thank you. It's an honor and a privilege to welcome Mr. Eoin Mc Grath for today's session, and this will be the first of its kind in the journey of TMAS, which is a society mainly looking into the academic activities in Kerala, southern part of India. And I am also happy to welcome Dr. Joy Maman and Dr. Asim Tiwari, two stalwarts in the field of data science, and who is working along with Dr. Joy Maman used to work with ICCBBA, and Dr. Asim Tiwari is now currently associated and affiliated with ICCBBA. So I welcome all three of you to the session and all the other participants. It will be a fruitful journey through the next 1.5 to 2 hours. Now, Mr. Eoin Mc Grath, who previously worked as a Director of Advocacy and Quality of Care at the European Society of Blood and Marrow Transplantation. He led the pioneering JC accreditation program, coordinated EBMT's interactions with European Union agencies, national regulations, and other stakeholders. And he also coordinated EBMT's successful effort to achieve a qualification opinion by EMA on the EBMT cellular therapy registry. Without wasting much time, I hand over the session and the stage to Mr. Eoin Mc Grath. Please go ahead, sir.
Thank you very much, Ganesh. Good afternoon to everybody. Just a technical question. Can you allow me to share my screen, please, so that I can run the presentation? Just while I'm waiting, so I really want to give thanks to TMIS for this opportunity. It's very timely because it comes at a time when ICBA, you'll see ICCBBA, but it's easier to say ICBA, is making a concerted effort to bring the concept of standardization, particularly in information standards, to India. And I'll go into a little bit more detail about what we're doing in that direction. Just waiting to be able to have the share button active. While I'm waiting, thank you for the kind introduction as well. And indeed, I'm just over 3 years with ICBA as the executive director. The organization itself has existed for over 30 years. It is a United States-based not-for-profit that is working in a very specialist niche area, which is the subject of this webinar today. The coordinator, I still don't seem to have a share option. I think I'll actually have to go somehow give me permission the settings in Teams. Can also just give an outline of what I will.
Sir, can you please share your slides, please?
I can't because it's blocked. The coordinator needs to give me the functionality to share. There is a setting, I'm sure, associated with my profile in Teams whereby I could be given permission to share. I see my camera now. I'm still waiting for the share option. It's in there among the settings somewhere for Teams. Okay, I see
So
it now.
now it's enabled, sir. Now you can share your slides,
Yes.
sir.
Okay, most kind. Thank you very much. So this is what I want to go over for the next, I estimate about 40 minutes of the presentation, and then we have plenty of time for questions at the end. I believe that questions, some have been sent in advance, and that some, you may also use the chat to post questions. So I'll just offer a little bit of terminology just to explain some of the terms I will use today. I will attempt to describe the challenge that we are trying to address with ISBT 128. I will go into some of the aspects of traceability, and then I will offer some more specific detail on ISBT 128 itself, and of course the organization, which is ICCBA. So in terms of terminology, today you will hear me use the term medical products of human origin, or MPHO, frequently during the presentation. And MPHO is a term used by WHO. You'll see it there at the beginning of the heading of that document from 2017. Another term which is very familiar to a European audience, which is substances of human origin, or otherwise known as SOHO. And that, if you see there, that's the most recent regulation from the European Union on qualities and safety of blood, tissue, cells, or any substances of human origin. But today you'll hear MPHO used frequently. And then just one other slide on traceability, just to share definitions. The first is from the European regulation, the ability to locate and identify substances of human origin from collection to human application, disposal, or distribution. And below you'll see from the MBTC standards in 2022, the second edition, traceability is defined as the property of the result of a measurement or the volume of a standard whereby it can be related to stated references, usually national or international standards, through an unbroken chain of comparisons, all having stated uncertainties, which actually I find a much more technical and perhaps even more complex definition than the one above. But nonetheless, we're talking about the unbroken ability to track and trace a substance taken from one person through a pathway or a chain to its medical application in another person. So the challenge we're attempting to address. So I have never found anybody to argue that traceability is a good thing. It's accepted, and it seems obvious as well that traceability is not a luxury, but indeed is a fundamental aspect which is built into everything that we do as professionals. Perhaps the problem resides in the fact that everybody assumes that traceability is covered, and they will naturally think of their day-to-day activity and feel a lot of confidence in their ability to track and trace all of the substances that are being processed or otherwise handled by their facility. Now, that confidence, of course, is somewhat undermined by the fact that we know that things go wrong. We know that things get lost. You don't have to go into the very deep into the professional or even popular media to find examples of issues with blood, with organs, tissue, cells, etc., in terms of possibility of infection, the risk of transmission, and in the event of transmission, of being able to go back to the source substances or source MPHO. This case here is from very recent years. I think it was 2022 and 2020 and 2022, which was a tissue contamination in the United States. And what really jumped out at me was that almost 4% of the tissues in this case were lost to traceability. And this is a bit alarming because while the numbers are low, 6 packages or 6 packs of this particular substance, if you extrapolated that to a national level across all tissues and cells, potentially the numbers are measured in the hundreds and the thousands. So even in the so-called rich world, traceability is not something that we can take for granted. This was a paper published in 2022. It was hazards of transfusion, and it was an analysis of where something went wrong. And this was whereby a patient was given another patient's blood. And I just highlighted there in red 2 aspects of this breakdown. And one of the sources of the error was the lack of validation by barcode, so that when the nurse was handling the blood, it was all simply by either reading or manually entering, but there was no ability to simply scan information on the label to confirm identity, etc. And the other detail, which I thought was very interesting, was if we, let me just get the pointer. Here we had an issue with the physical space. One was that there was very low lighting, and the second was that they had black letters on a red blood bag, which made reading clearly the information more difficult. So these are examples of where things break down and can lead to a risk to a patient. If we look as well, there's a couple of examples from India. This was a study from 2016, and a report on errors in pre-transfusion testing. And they identified, and I think it was a single center, but they identified 8 errors of labeling on blood bags. Thankfully, 6 of these errors were detected before they were issued. But nonetheless, 2 did make it to the patient and led to adverse events. And that's, I think, a more recent paper, 2018, Nature and Causes of Errors in the Blood Transfusion Chain. And in this case, most common type of errors in the study of that particular institution were labeling errors. Again, many of them were detected during rechecking, so thankfully their process was sufficiently robust to catch these, but of course it necessitated then of what may be a laborious and time and resource consuming second check at the time of cross matches. So traceability is important because it helps mitigate transfusion transmitted diseases. So even if transmission occurs, at least gives the ability to detect and then to address the transmission with an appropriate regimen for the affected patient. It allows you to more accurately and more quickly retrieve from archives, and I'll talk about that a little bit later. It gives you the ability to follow up on those adverse events. It can mitigate risks related to critical product issues and recall defective products, where there may be a blood bag recall or other equipment. You can identify products that were somehow associated with those products. And then, of course, it's a cornerstone of hemovigilance and more widely biovigilance. We would say that the fundamentals or the prerequisites of traceability systems are being able to uniquely identify each MPHO product that is collected. It has to allow for secure mapping. Some background noise there. Could somebody mute, please?
Admin, please mute every participant.
Thank you. So secure mapping from the donation to the donor and the recipient. Mechanisms to, it requires the mechanisms to absolutely capture and store that critical information for the duration stipulated at minimum by legal requirements. Preferably, it's not a must, but certainly preferably the use of electronically readable information and data storage. So that would be barcodes, whether they're linear barcodes or data matrix, or other instruments that allow for automatic reading. And then finally, real-time tracking and recording of each step in the life cycle, which necessitates that electronic systems. Now, what works against traceability, or at least what makes traceability far more complex, there are a number of factors. Of course, we often divide or pool products. You may be challenged by data storage devices or formats which may be no longer supported. The very elderly among us may remember diskettes, whether they were the bigger floppy disks or the smaller diskettes, hard drives, which are no longer suitable to work with a USB-C plug-in, etc. So there may be in institutions like hospitals or wider medical institutions where change, especially in technology, can be slow and where inertia can often take place. You may be working with data storage systems which simply cannot be supported anymore. CDs is another example. I think you would be hard pressed to buy a computer nowadays that can actually read a CD or a DVD. Data migration issues. So moving data from one system to another system is complex, and it may lead to errors, and therefore that error may lead to a breakdown in being able to track and trace all the way through a product and a patient pathway. The use of paper records, which are vulnerable to mishandling, water damage, fire damage, etc. Organizational restructuring. So we all have worked in organizations which have been subject to takeovers, to reorganizations, upscaling, downscaling, and all of that can disrupt the ability to have end-to-end traceability. The traceability chain itself can be subject to disruption. Your audit trail, because of the reasons stated previously, may be vulnerable. And in all of this, the required uniqueness, where as soon as you have a risk of duplication or repetition of an identifier, that is automatically a big vulnerability in your ability to track. So if I turn my attention now to India, and you will all be familiar with this data. It's taken from the Iraq portal. This data is from over a year ago. So those numbers have no doubt changed a little bit since then. But the context that we were all working in is a growing sector. We have a growing number of blood banks, which I would say is over a handful of years, and certainly since COVID has grown by probably over 1,000. We see the breakdown of blood centers between government. Can you mute, please?
International Society of Blood Transfusion.
Yeah, I'm just going to mute that person. Thank you. You have different actors and stakeholders. You have government, you have NGO and charitable, and then you have the private blood centers as well. This brings a degree of complication in terms of perhaps making it more difficult to achieve standardization across organizations of different natures and different characteristics. And then you see this happily growing number of units collected. I'd be curious about the final numbers for 2024 to see if that trend continued. But this also brings the challenge, of course, of being able to safely handle and track and trace that increased volume of units. Again, looking at India, and of course, we have the NBTC standards for blood centers and transfusion services, 2022 version I'm looking at here. And these standards, unsurprisingly, make dozens of mentions of label, several mentions of traceability. Barcode is mentioned twice, and I've just cited the two clauses or the two standards that require this. Both of them are written in such a way that they are recommendations. You can see the use of the word preferable, and here we can see the use of the word should, without them being what we would say a shall or a must standard. But nonetheless, this is certainly a way to nudge the sector towards barcoding and electronically readable information. As another complication, perhaps in India, is the fragmentation of the sector, and you have services being delivered at local level, at hospital level, at regional level. And this was, we just took one example of Trivandrum in the state of Kerala, 28 blood centers, blood storage units across 100 hospitals. And you have this transfer, this bulk transfer between blood centers. You have records being kept for only 5 years, which strikes me as a very short time. Just to give you a comparison, the European Union equivalent would be 30 years for tissues and cells. Blood, actually, now that I think of it, I suspect it's also 30 years as well. And you have a mixture of systems there as well, both electronic and manual in this, or what I call a complex network. And I would seek to with this example here, to try and illustrate what I would observe as a potential risk. So I can't say that it's actually happening, but I would perhaps alert us to consider whether it is as improbable as we would like to think. So here we have a hospital being supplied by 3 blood centers, blood center 1, 2, and 3. And blood center 1, you can see the blood bag, and it's got what is probably a very simple, but I would say common kind of sequence to identify each blood collection. They've taken 2 digits of the year, and then they've added a 4-number or 5-number sequence, in this case, 4 numbers. And this is perfect for working within that blood center. It's likely that each of those identifiers will be unique. The issue perhaps is that given the perhaps obvious nature of the sequence of the it may be used elsewhere as well. And here I would illustrate that you could potentially have several blood centers supplying blood to a single hospital with the risk of using an identical format, which could then lead to the hospital having identically identified blood units, and consequently making traceability at the very minimum complicated, if not downright impossible. Okay. Second aspect then, just thinking of barcodes, and we've seen it mentioned in the MPTC standards, and this is an example from India of a blood bag which featured just the one barcode, and that if you scan that, and indeed I checked this yesterday, if you scan that code here on the left, it will indeed return correctly the numbers 206745. But that's it. Every other item there is possibly manually entered. Very difficult or impossible to capture the other information, for instance, like FFP and the expiry date in the blood group electronically without requiring some manual entry. On the other hand, and we'll show this in more detail a little bit further, here you have an ISBT 128 standard label where 5 or 6 critical information items are captured in a barcode. And I'll go into a little bit more detail on that format a little bit later. Earlier, I mentioned traceability, and this was a case which was actually only recently resolved 2022, even though the actual initial incident happened in the late 90s. And among the issues here in the court case which emerged was the inability to track back to the original blood units. And here the court highlighted the inability of the hospital to produce the blood bank records. And in this case, of course, and I mentioned the 5 years of the requirement for archives of records, you can see that clearly this is going back far more than 5 years. And this is mentioned down below. So the need for traceability is both a day-to-day necessity, but also a much longer-term necessity as well. And this is something that I came across recently, or was pointed out to me by Dr. Shivanand Komatagi. I'll highlight him a bit later, but this should be familiar to many of you, which is the Hemovigilance Program of India and the reporting form. Clearly, it's just one section of that lengthy form, but one of the requirements is the need to identify the type of component that was subject of an adverse event or an adverse reaction, And all of these elements could be encoded in such a format to make reporting of this information, which right now I understand is quite laborious, could be made far easier without the need for manual forms. So I'm quoting heavily now from an article which was published in 2023, and this was published in Vox Sanguinis. It's the guidelines for traceability of medical products of human origin. That paper is open access, and indeed you'll see the citation there below with the DOI code. But just to walk through these items, information to retain for traceability. I'm looking now at the column on the left. So the information linking, this is the information that needs to be retained. We need to retain the information linking the donor to the donation identification number. So we need to be able to link the product to the donor. On the other side, we need to be able to link the recipient of the product to the same donation identification number, but also to the product description code and to the division number in the case that the product was subject to a division. All of that is to identify the specific portion of the MPHO and link it to the recipient. So it's not good enough to, if you like, connect it to the mother product, but you must actually make sure that you're identifying the subdivision that was actually administered to the patient. You have to identify the processing facility, and if it's different, the collection facility. So often and usually probably they are the same facility, but they may be performing different parts of the process. You need to be able to identify pooled products in the event that a product is pooled. You need to be able to track and record all the steps in the handling of the product. So that allows then for a stepwise investigation into the product. And we know that in many cases, it's processing steps are the origin of an issue with the product rather than the original product itself, as in contamination happens within the collection of the processing facility, not in the original donated product. Where products are transferred between organizations, you need to be able to retain the sending and the receiving organizational details. Again, once a product leaves your direct control and goes to another site, you need to be able to somehow link between the two organizations. And you need to know what happened to the final product. Was it administered to a patient? Was it left in storage? Was it disposed of, for instance? All of that needs to be documented and preferably encoded in such a way that your inventory, for instance, is kept up to date in real time as well. And in all of this, you need to be able to identify the location and the methods of access to those records for traceability. So again, I referred to data format earlier, or formats. That's part of what needs to be documented. So I think the argument or the case I'm making throughout the webinar today is the case for standardized information. And I think, and this is a very simplistic breakdown, but I think we can summarize that non-standardized information carries the risk of inconsistency. But from individual to individual and from organization to organization, you can have variability in terminology, in coding, in formats, etc. And the rules can be unclear. And in all aspects of our day-to-day work, we're all familiar with cases where one professional does things in a way different from another, and the desire that, that everybody is following a standard operational procedure or a protocol, etc. So non-standardized leaves open that risk of variability because the rules are not well defined. It can lead to inefficiencies, and particularly the need to re-identify a blood bag, for instance, at every step in the process as well. And then all of that has safety implications where you have duplication, or you have missing information, or you have errors, data entry errors, which can then break that chain of traceability that we've talked about. And on the other hand, standardized information brings that clarity. Standards or specifications, if you like, are the rules that we all agree to follow, so that it makes it easier and more efficient to train, to follow, and to enforce. It adds a layer of safety because, for instance, if we talk about unique identifiers, because it's standardized, it reduces or minimizes or hopefully eliminates the possibility of duplication. And consistency, again, it addresses variability, potential for confusion. Importantly, it makes data interchangeable, and that necessity is becoming more important as our hospitals and our health system in general becomes more joined up, becomes more digital, and the benefit, which everybody can see, of having complete records in a single place for every patient, all of that fundamentally requires that we can actually move information with no data loss from one system to another, otherwise known as interoperability. And all of this just at a blood level allows for that exchange of blood between organizations in an efficient manner, reducing or removing the need for re-entry of identifiers and other critical information. So as I start to introduce ISBT 128 as part of the solution to some of these challenges, I would itemize them here. That tracking and tracing, part of the solution of that is having a unique donor or donation identification number. That identification errors, limited information and labeling space for the large amount of information which is often required by regulators. For the efficiency purposes and for supporting automation, all of that comes through barcoding. The challenge of interoperability of different systems, of moving blood products across organizational lines, geographical lines, political lines, all of that is by standardizing, so we have globally uniform information. That variable names for the exact same product can introduce complexity in knowing precisely what product is in question. All of that can be addressed by standardizing terminology and introducing product codes, so that we are talking about apples always when we talk about apples and oranges when we talk about oranges, and not mixing. And finally, then, the ability to transmit the information through these various formats: barcode, 2D symbols, radio frequency ID, and electronic EDI, I think is electronic data, EDI, sorry, I can't recall. It allows you also then to adapt to changing regulations, perhaps, and more importantly, adapting to the advances made in the science and in the medicine, etc. And all of that can be addressed through data structures, which have an inherent flexibility, which allows them to adapt as well. And I just want to really focus on what I would say is a fundamental element of traceability here. And this I'm quoting from the JPAC, which is the Joint United Kingdom Blood Transfusion and Tissue Transplant Services Professional Advisory Committee. So this is an important part of the national health system in the UK. And in their documentation, they are emphasizing the uniqueness of identifiers. And just highlighted in yellow, of course, is that effective traceability depends upon those key identifiers remaining unique. And this is important to emphasize. Unique at the time of being issued is good, but not sufficient. It must remain unique. The experience of Codabar, for those who remember Codabar, was the realization that numbers were being reissued due to a fundamental vulnerability in the format of the Codabar specification. So remaining unique throughout the domain that the MPHO circulate in and across the period of record retention. The donation identification system must be able to ensure that donation identification numbers are not repeated during that period. And if historic records do not use such a numbering system, there may be duplication of identifiers over time. And the archive system needs to accommodate this and ensure the integrity. And for that reason, ISBT 128 was adopted within the national NHSBT as their expected standard. So I've mentioned ISBT 128, I've mentioned ICCBA. I just want to illustrate the difference between the two. ICCBA is the organization and ISBT 128 is the standard. We've recently have been going through what would I call a rebrand or a refresh of our identity. And one of the areas we wanted to address was a certain confusion between the two. So if I talked about hierarchy of the logos, ICCBA will be at the top, and then ISBT will be at the below. So if you like, it's the company or the organization and the product are these two. So that was one point. I just wanted to really get clear in your minds the difference. So if you look at the standard, ISBT 128 is the international standard for the transfer or transmission of this information through two means. One is through labeling of barcodes, and then the second, which I'll mention just briefly, but this is electronic messaging. This is the ability to transmit information between systems beyond the label, and that I'll come back to this point a little bit later. The fundamental, the foundation of the standard is what we call standardized terminology, and the document you can see there is it's in the public domain. It's on our website. You can download it through the link that's there, and just on the right you can see an example. But this is effectively a set of terminology that has emerged from 30 years of expert consensus on what something should be called and a definition for that product as well. So the necessity for standardized terminology comes from the need to make sure that we are accurately and clearly talking about the same product, and to remove ambiguity in terms of identifying what is in a given bag. The second part, bigger pardon, this part now I've come to the label itself, and you've already seen an example earlier, but I'll just dive into a little bit more detail. First thing to notice is that the standard defines the physical layout of a label. So it sets the technical specifications of what information needs to go where. You'll see that it's divided into these 4 quadrants, and each quadrant is the space in which specific data items are expected to be displayed or presented. So if I go to the first quadrant in the top left, this should always be the donation identification number. It should identify the facility, and it should identify the collection date or production time. In the top right-hand corner is the blood group and RH type. I go to the, beg your pardon. Bottom left-hand corner is always the product code and the dimensions. So product code is this number here, this barcode, which will always return the same output, same clear name of the product. And here are the dimensions, which may be storage, the actual volume, etc. What I didn't mention here, and I believe it's part of, it indicates whether it's a volunteer donor, replacement donor, etc. Clearly in the stated policy is that all donations are volunteer altruistic donors, but this may be an important element to be included on the label. And then going to the 4th quadrant in the bottom right, we have 2 elements: expiration date and time, and then optionally you may also include special testing that's been performed on this given product. So by specifying and stipulating the exact position of each of these critical data elements, this leads to a degree of familiarity, so that as a product moves across systems, the operators will reasonably expect to find the same information in the same place, which again lends itself then to efficiency and good handling. The donation identification number, which we've identified in the JPAC manual, just to break it down for you. The very first part here is and a facility identification number. That you'll notice that that number, which is 5 characters, is assigned by ICCBA. So we have effectively become these curator or a steward of unique facility identification numbers for every facility that is registered with ICCBA. That's now measured in terms of, I think it's about just over 6,000 individual facility identification numbers active at this point in time. The second element are the two digits of the current year. And then this final part is the sequence number, which is assigned by the facility itself. So the contribution to this number is from ICCBA is the facility. The year is something obviously that exists of its own right, and then the sequence is something that is generated from within the facility's own system. But it would always be those 13 characters. The elements on the far right, the flag character and the check character, are one is optional. It allows for process steps to be controlled as part of this identifier, but it's not part of the donation identification number. And the check character is there to control that the manually entered data is correct. It does a calculation in the background to make sure that what you enter is in fact correct. Now, one thing that I've heard often, at least here in Europe, is this idea that blood doesn't move. And as you probably heard in my introduction, I came from working with stem cell transplants. And of course, anybody familiar with that area will know that approximately half of stem cell transplants are allogeneic, so that the cells are moving from a donor somewhere to a patient elsewhere. That might be within the same country, but very frequently and increasingly they're moving across borders as well. So that when I came into contact with blood, I was struck by this idea that blood doesn't move. And what I've learned is that is not absolutely true. And in this case, I've highlighted the rare blood. Many of you will be familiar with the International Rare Donor Blood Panel. And increasingly, India, of course, and as it's probably natural to expect, particularly the Bombay group, is something that is exchanged within India, and in a small number of cases where donated rare groups have been also sent abroad as well. This is something that I think will probably increase in importance. I think the idea of more joined up blood systems that gives everybody access to particularly these rare blood groups, I think is in everybody's interest. And that necessitates a mechanism that accurately controls blood that moves out of a given blood bank where it is well controlled and into another facility or another institution, or indeed another country, as I mentioned as well. The second element of perhaps contradicting the assertion that blood doesn't move is part of the national management of blood within India itself. And these are a discussion in the parliament going back to 2015. And this was from NACO writing or bringing to the attention of the Ministry of Health and Family Welfare the idea that bulk transfer of blood between licensed blood banks should be facilitated, so that surplus blood in one area can be moved to areas with blood deficiency. And you can see there in the response from the minister about policy that does approve this blood, and necessarily it requires as well those mechanisms that I've mentioned of being able to ensure unbroken traceability as blood moves out of, let's call it our comfort zone of my blood bank, my system, and moving it into a foreign, an external system that you don't control. Going back to our blood label, I just wanted to highlight the blood the product code description or product codes. And I wanted just to explain where they come from. So a product description code is a 5-character code which has been generated to describe a very specific combination. Now, I've given you some examples here, but I can tell you that there are thousands of PDCs, product description codes, each of them uniquely identified in order to specifically identify a given combination of the product itself, anticoagulant, the volume, and the storage. Each of those elements are all framed in this 5-character code. Now you can see that the degree of granularity that's reflected in those as well. Product codes emerge from ICCBA, but they emerge from expert discussion. And what can happen is that somebody who is subscribed to the product description code database through being licensed by ICCBA may see a need for a given code for something that they have in their blood bank. They either may have not been able to find it, or they may believe it doesn't exist. They can put a request in. The first step that we will always do is ensure that there is not already a pre-existing code. In the event that is a new product, then that goes through our TAG, which is our technical advisory group, which is a group of subject matter experts. And from there, if it's decided that a new code is necessary, that emerges as a recommendation. It's then incorporated into the product code database, and within a matter of weeks, then that becomes available, not just to the requesting center, but to every center who is subscribed to the database. So the ISBT 128, as I say, has been around for 30 years, and over that time, it's been strongly backed by the main blood organizations. You can see there from the Global Advisory Panel from Red Cross and Red Crescent, from the European Blood Alliance, and from ISBT, all of which have made public endorsements of the standard. I would also point out that ISBT 128 has been incorporated into the regulations of several countries, and I would just pick out in the tissue and cell area that ISBT 128 is known as a permitted coding system within the European regulation. Within Brazil, since 2012, ISBT 128 is mandatory for blood and for plasma collected in Brazil. And FDA, going back several decades, have also recognized ISBT 128 as a suitable standard for meeting blood labeling requirements. I'm very proud to emphasize the global nature of the ISBT 128. It's a standard written and designed to be globally applicable, not to be used just in the United States or in the European Union, but to be globally applicable. And this picture, it doesn't indicate volume by any means. It just indicates where at least one registrant or one facility has subscribed to ISBT 128. But it does give you a flavor of the global character of the standard. That being said, it is fair to say that, and this reflects the origins of the standard, its strongest and highest adoption is North America, particularly in the US, followed by Europe, and then to a lesser extent in other regions, Middle East, Latin America, South Asia, Sub-Saharan Africa. The numbers on the top right-hand corner show the number of PINs, the facility identification number that I referred to earlier. And as I say, I think it's 6,082 or something since last week. Now, ISBT 128 is known within India, that's clear. That's thanks to work done by some of the pioneers in the areas, for instance, Dr. Joy Mammon in Vellore and Dr. Asim Kumar in New Delhi as well. And this is also reflected this is the 2023 Transfusion Medicine Technical Manual, where it points to ISBT 128 as a system for identification, labeling, and information transfer of medical product of human origin. And this is interesting because I don't believe that the technical manual refers to other external standards. So I saw a certain significance in this more recent update of the manual. And it also sets some expectations around electronic blood center system as well. That being said, and given the size of just the blood sector in India, with the numbers that we saw earlier in the presentation, we have just a handful of currently subscribed facility and centers, and a number of them, in fact, I think the majority are probably cell therapy facilities, and among them are these perhaps private core blood banks. But there are also a number of blood facilities as well. This I referred to earlier in terms of data transmission. We've talked extensively about labels and barcodes, but I just want to give a quick reference to electronic messaging. And as the need for more information to be transmitted increases, we have probably are close to reaching the maximum capacity of the physical space that is a blood bag label. There is only so big you can make a label. Blood banks are only so big. And even with barcoding, there is still, as I say, that's the physical constraint. So in order to actually still be able to supply that critical information in electronic format so that I can move from one system to another, it's the idea of electronic messaging. And one of the areas that ICCBA has worked heavily with on rather over the last, I would say, 10 years has been to align ISBT 128 with what is called HL7 Fire. HL7 Fire is another standard for moving data from one system to another, so that compatible systems are capable of receiving, interpreting, and correctly placing information as it moves between systems. And this becomes significant in the context of getting data out of the classic silos. One silo would be the blood bank. Another silo would be the hospital information system. What you really want is that the critical information of a given blood product that is going to be administered to a patient by the bedside in the hospital is that you can bring that product information all the way into the patient record. And we know that there's extensive work being done on interoperability in India. And on the far left, you'll see here, this is simply a list of other health information standards that are being implemented and released across the Indian healthcare system or information systems. And for me, it shows a predisposition of the authorities towards adopting international standards. And I would place ISBT 128 among them, albeit a very specialized niche area, but nonetheless addressing a critical, often life-saving product whose traceability, as we've emphasized over and over again today, has to be guaranteed. So we have had very fruitful conversations with CDAC, the Center for Development of Advanced Computing. CDAC have done work on these standards. For instance, they are a National Release Center for SNOMED, clinical terminology, for electronic health records, for LOINC, laboratory observations, for DICOM, which is an imaging standard as well, and as I just mentioned, for HL7. So my sense right now is, again, it's an openness from the colleagues at CDAC to incorporate ISBT 128 into their thinking and into their system design as well. Just to into the last part of my presentation, and it's just to give you an insight into the organization itself. ICCBA emerged out of ISBT back in the late 80s. Codabar was basically identified as a problem. It had been a solution, but its very design made it difficult to, it wasn't able to keep doing what it was designed to do, which is to generate unique identifiers. So in order to find a solution for this, a working party within ISBT was established. From that, the standard emerged in the technical specifications. One key element from the experience of CodaBar, one key element was identified, which was to ensure the sustainability and the continuity of the standard. CodaBar had no organization behind it, so consequently, it gradually, probably better said, became obsolete as practice, sheer volume, and technology changed. So consequently, ICCBA was established as a standalone independent organization, not for profit, registered in the United States, and that it would be sustained through a license fee model. We have been in official relations with WHO since 2014. ICCBA, like any of the non-state actors, are subject to a scrutiny in order to qualify. So this is important to us to demonstrate that our not-for-profit status and our mission are in line with WHO's interest and objectives. And essentially, we do two things. We are a standards development organization, an SDO, and we develop everything I've been talking about earlier today, the terminology, descriptions, the data structures, the label design and format. We issue this critical facility identification number, and that is the key element of unique identification. So standard development on one hand, and then this additional task of curating and stewarding this database of facility identifiers. And as an SDO, what do we do for the users? Well, we're stable. Means that it gives confidence in a standard that has been around for 30 years will continue to be around in another 30 years. Certainly, that's the objective. User focus, so we have spaces and fora within which end users and software developers, hardware developers can participate in the design of the standard. It is driven by experts. So all of this is consensus driven. The standard has demonstrated its flexibility. It originated in blood, but has been adapted to, I think, at least 7 other groups of human substances since then, including cells, tissues, organs, fecal microbiota, human donor milk, etc. We would pride ourselves on our responsiveness and our help desk in offering solutions to challenges that our users are facing. And we are also offering increasingly education and instruction to users. We are location agnostic. Yes, we are US based, but that doesn't stop us being relevant in all locations and extensively taken up around the world, as I've showed with the map. Interoperability is now being embedded into our DNA, I would say, and we're a small organization. Actually, that number is now 14 full-time equivalents, 1 office, but that picture is changing slightly. Just collaborations, we have different degrees of memorandum of understanding and other agreements with European Commission, with FDA, with other standards organizations, with ISBT, with ISO, etc., etc. We are governed by a board. All of these members here are subject matter experts drawn from different parts of the world. And I just highlight that currently India is represented by Dr. Aseem Tiwari, who succeeded Dr. Joy Mammon, who served for 6 years on the board previously. But other members are from the United States, from Europe, and from South America as well. And I'm essentially, as the executive director, I'm essentially answerable to that board, and I direct then the team based in the United States. For those of you who have found this to be interesting and something that you wish to either find out more about or to directly pursue, the steps would be certainly research and learn more about it, to importantly align so that your colleagues also are on board with any plans to incorporate the standard into your systems, and engage with other stakeholders. And we all work in complex organizations with a lot of codependency, so the necessity to include key contributors like your IT support, like your payer, your hospital administration, or other authorities is key. And to avail of that support that we can give you from our help desk and from our other materials as well. Ultimately, if the decision is taken to proceed, then you will need a facility identification number, so that requires you to register with ICCBA, and then the implementation phase as well. There is a guide for ISBT 128 in what we consider resource-limited countries. That guide is from 2022. It is going through revision, and we hope an improvement, but nonetheless, that document is there in the public domain. Just to touch on costs, because costs is one of the barriers that we often come across. And you'll have heard me mention the license, and why do I have to pay ICCBA? So we would say that for the reasons I've already mentioned, but that if you commit to a standard, you do not want to have to change your system and your setup and your training, etc. in 5 years or 10 years time. You want to know that it's going to be around long term. Your work and your field is not static, it is changing. The products that you're handling now are possibly different from what you were handling 20 or 30 years ago, or even less. So all of that requires a standing organization that is sustainable and will continue to support and adopt the standard as it progresses. So how much does it cost? It costs full fees will be between $315 and $480 a year. These are US dollars. There are discounts for lower middle and lower income. India right now is classified as by the World Bank as lower middle, so there's a 33% discount. Our rough calculations when we've looked at this have we've attempted to compare it to how many blood bags does a license fee is it equal to, and we consider that for smaller blood banks collecting under 1,000 units a year, that's about 36 blood bags, and for those bigger units up to 20,000 units per year, it's a very wide range. As you can see, it's equivalent to around 56, 57 blood bags. So the annual license fee is equivalent to approximately those numbers of blood bags that you see there. I can't not mention vendors. So it's been mentioned a couple of times, and we say preferred electronic systems, but it's very hard to do this manually. So really what you want is a good IT system, good software system, combined with effective and efficient hardware as well. And there are dozens of license vendors. So these are vendors registered with ICCBA who pay a license fee to us to incorporate the standard into their solutions. Over 100 licensed around the world. However, right now in India, there are none, and there have been in the past. But when we've met them and talked to them, what they've said is that there has been no demand for this feature from the end users, from the blood community. That will change if, as we already detect, an increasing interest for using ISBT 128. So I'm hoping that that picture changes. I'm hoping that we can convince or help convince those vendors of the probable interest from their customers and future customers to have ISBT 128 so that they re-register or register for the first time. We've met with several of them. They're non-committal at this point, but I think if it can be mentioned in any conversations you're having with your vendors that this is something that you would probably be interested in, or possibly, that would hopefully nudge them towards re-engaging with us. Implementing ISBT 128 is hard work. I think anybody who's had that experience will be able to confirm that. It is not plug and play. It's not software. You don't download it and somehow install it. It is built into systems, but it affects so many aspects, whether what your labels look like, it affects the systems. I mentioned the training, getting your colleagues to think in terms of standardization. All of that requires cultural change, behavioral change as well. So the implementation curve and learning curve is steep, and your system providers also need to be on board, and they also need to be adapting their system as the standard updates as well. I've mentioned where information can be acquired from. much of that, or practically all of that information is in the public domain. In fact, probably the only thing which is not in the public domain is the product descriptions code database, the PDC database, which is only available to licensed facilities. I'll mention our grant. This is a grant scheme that's been running since around 2017. This is awarded by ICCBA to organizations who have presented a proposal. Anything that builds capacity in terms of traceability, in terms of trace safety and quality of their processes. We award up to $50,000 per organization for projects that can be completed in 12 months. We're in the process of making our awards this year. The next call for proposals will open January 2026. I think the deadline will be approximately end of March 2026, with the awards hopefully made in mid 2026. So please give that some thought and watch out for announcements to this effect in the last quarter of this year. And if I attempt to summarize, our patients and our donors, they deserve safe and efficient care. We believe that standardization brings clarity, reduces errors, helps address those problems of fragmentation that we've touched on today. They help address inconsistency and ambiguity, which can be a source of risk. ISBT 128 is established, 3 decades. It's stable, and importantly, it's self-sustaining, widely endorsed globally. It's been proven to be adaptable and responsive over that time within each, across MPHOs and within each MPHO as well. And I would stress the openness of ICCBA as an organization to collaborations and to entering into dialogue about how best to take this up. I've quoted heavily from this article today, so that's the citation. And it would be remiss of me not to highlight, I think, probably the most significant development for ICCBA, not just in India, but I think in ICCBA globally, which was a very new role for us. And this is what we've called a development officer. So recognizing that being US based, I personally am based in Spain, but being that distance is a factor we want to close that gap to the end user. So I'm delighted to say that I think it was in July, approximately a month ago, we were able to appoint Dr. Shivanand Komatagi as ICCBA's very first development officer, certainly the first in India. And I would have to say that since Dr. Shivanand has started, I've learned more about Indian blood in 4 weeks than probably in the last 3 years. And I would strongly encourage you to contact him. You can see his ICCBA email there as well. Of course, his LinkedIn. And I believe he's also easily contactable through WhatsApp as well. So through his work, and also I mentioned as well, Dr. Asim on the board, and then Dr. Joy as former board member, we are looking to be more present at the events in India, engaging through the national societies and the associations. And we certainly will hope to be able to engage with the national authorities and national agencies as well, in order to convince the community and the regulators of the benefits of standardization. And with that, very long presentation, and I'm very glad to see most people were able to stick to the end. I'll come to I'll finish, and thank you very much for listening, and very happy now to go to questions at this point.
Well, thank you, Eoin, for wonderfully explaining about the structure, function of ICCBA, what is the role of ICCBA, and what is ISBT 128 stands for, how is it useful, and how significant it is in our day-to-day life, and describing what is the current status in internationally as well as in India as we speak now. It was a very interesting topic as well as very eye-opening thing. And Now I can suggest all the participants, if you have any questions, they can unmute themselves or raise their hand using the button and ask the questions to Eoin if you have any suggestions or questions. I think Dr. Manisha has raised her hand.
Yes. So, Oin, thank you once again, and it's always nice to
How are
listen
you?
to you. Um, I have some questions now since we had really a very good technical discussion this time, although we talked on various forums earlier as well. So I have some very basic questions. Maybe you may have answers to them, or maybe we can have more clarification on them.
Okay.
First question is, I understand the structure of ISBT 128 that you explained, and then I can see there are 4 quadrants and the way they have been, packaged and the barcodes for each of the quadrants. Um, so why I mean, is there any plan to go from barcode to QR codes in future? Because I understand barcodes were the key at the time a few years back. And you
Yeah.
had the limitation on barcodes on the number of characters, which is 80 characters or some numbers. And that's why possibly multiple barcodes. So I'm thinking more from the ace of implementation point of view, because India is again a greenfield right now. And if we had to adopt a standard, we have to be really, really very cautious about it. So
Yeah.
what about adopting new technology? For example, one single QR code giving me all the details of the standard. And of course, I mean, the need is completely understandable, and there's no doubt we need to adopt. But I'm just thinking from the implementation perspective. That was first question. Do
Okay.
you want me to ask all my questions at one go, or shall I take a pause?
No, let's go one by one because my memory won't.
Done. Okay.
So you pointed out something, and I should have had a slide on this. So there are, and in fact, as we're speaking, I'm just seeing if I can dig up a slide which addresses that question about. Yes, I can perhaps share, and I'm hoping that you can see an image here with. Standard
Yes.
delivery mechanisms. Great. Okay. So you're right. The linear barcode has been around for, I believe, since the early 70s. In fact, so it's very established, and it's got its limitations. And the limitation is that it's called code 128 precisely because it can encode 128 characters. Okay, that is progress from Codabar, which I think had a limitation, but I think it was under 40. So that's part of the reasons why Codabar failed, and why ISBT 128 became the solution. Now, what you called a QR code is in fact a data matrix. A QR code, I think, will always bring you to a URL, and it's very useful to allow somebody to access additional information. So for instance, in pharmaceutical industry, there is a concerted effort with the regulators to move to replace the paper prospectus with electronic product information. I think that's EPI, whereby the user is brought to the most recent and updated product information. So this is a progression from static paper prospectus. However, QR codes have their own limitation as well, which I think is why they can only be used for URLs. So what we talk about are 2D symbols or data matrix. Now, should be able to just do this. Yeah, so the point you're making, which is very valid, is that in one data matrix code, we can include, in this case, the same information that is contained in 5 barcodes. And clearly that has, if it's one bag, it takes, 5 seconds to scan 5 codes. And of course, now it takes 1 second, but if you multiply those seconds, it adds up to considerable time savings in a big blood bank or a big facility. The constraints, I believe, are one, necessity for newer scanners. Now, by newer, I mean scanners believe somebody said that any scanner purchased in the last 10 years can probably do this, but it goes from laser scanners to, I've heard them called camera scanners. So that's one factor. That, again, one scanner in itself may not be very expensive, but again, if you multiply it by dozens, that can add up across a big system. I believe there may be more complex implementation. And the reason I say that is even though the data matrix has been configured in ISBT 128 for, I believe, 10 years or more, we're only really now seeing some blood services moving in a concerted way to that. I'm thinking of in Denmark that they have made this move. The difficulty is that they still have to maintain the old linear barcodes for a transition period while everybody else catches up. So it is, it could be, you said India's green field, and it's always that analogy of going from no telephone directly to mobile phone without passing through analog. That may be potential, there may be potential for doing that, and it's certainly worth investigating. If you don't have the legacy of the older barcodes, maybe that potential is there. The point I think I would be cautious about is the added complexity about implementation, although I would need one of my technical colleagues really to speak to that point. So does that answer your question, Manisha?
Yes, but I just want to reconfirm. This would be possible, right? I mean, the standard doesn't change that way, right?
No. The standard, if you like, the barcode is simply a delivery mechanism, and the delivery mechanism for those well-structured, well-defined, and stable data structures. So how you transmit the information is simply
up
an
to the
alternative.
technology part. Yeah.
Yes.
So
exactly.
On the similar line, my next question is about the licensing, and what does the licensing facilitate? In the sense, one is giving an facility identifier, the namespaces. Does the licensing also provide you to generate a barcode, and then the printing and of course handling through the devices would be the facilities part, but what all is covered when you say a license? That I'm not sure whether I missed it on the slide, but I had this question.
No, it's a very good question. What do I get for my money? I think is another way to put it.
Of course. Yeah.
So I think that the most important two elements are as you say, the facility identification number with the guarantee that will, be maintained as unique, and that's globally. So nobody else will be given the same identifier. So consequently, your DIN, your donation identification number, retains that uniqueness. The second element is the access to the PDC, the Product Description Code database. As I mentioned, that is simply the only proprietary, and that's the wrong word. It's the only area that's restricted. All of our technical specification and guidance and instructions, etc., are in the public domain. Yes, they have a copyright, but anybody can go in, download it, read it, study it, etc. What you can't access is the PDC database, and the PDC database you would need in your IT system somehow linked to it through whatever means in order to actually be able to select the code so that it then returns that clear description in the bottom left-hand quadrant, if you remember from the label. Now, we issue an update of the product description code approximately every month. It's probably 10 updates per year, maybe even 11 or 12. Now, that doesn't mean that every month the same product is getting a new code. It's simply that we've added a degree of granularity. We may have entirely new products added to it as well. It's true that for let's call it a normal blood bank who collect and issue approximately 20 types of blood products with practically no exception. Ultimately, they're going to be drawing down on the same 20 product codes time and time again. But the subscription is that you're always making sure that you're drawing down from the most up-to-date version of the code. In some cases in the past, codes have been retired, but they're retained in the database in order to make sure that systems are backward compatible. So a code, for whatever reason, is retired, replaced with a new code, but the old codes are retained there as well, so that you don't essentially have a blank space in your system because using an old code. I think perhaps in the past there was an understanding that support was only available to licensed users. That isn't the case. Our help desk will take queries from implementers, whether they're licensed or not. Our interest is always that implementation is correct. We're aware that because of it's not plug and play, that there is some variability in how well people implement. We always say you have to follow the instructions, in detail. The instructions are written very much for a technical reader, and that is very satisfying for the software developers, your IT colleagues. It's less satisfying for the non-technical expert attempting to grapple with this. But I'm emphasizing now that support is available even for users who are just at that exploratory phase and are just trying to clarify concepts and get advice. So in summary, it's maintaining your facility, issuing and maintaining the FIN, the facility identification number, and then access to the product code database.
Would that also cover any knowledge resources or education material? I understand most of it is resources are free for access for anyone, right?
Yeah, we haven't put a paywall or restricted access. I don't believe it's in our interest that that information is somehow maintained behind a barrier. I think it's in everybody's interest, not least of all the patient and the donor's interest, that everybody is doing this the right way. Yeah.
Right. I guess last but one question followed by this is we just looked at the licensing costs, and I'm just thinking from the National Resource Center perspective and from the Ministry of Health perspective. Unlike other IT systems in India, we have centralized blood bank that is getting implemented. And I think that's the plan, to have it implemented at maximum places as possible. Now, if it's a centralized blood bank system, and then you have these multiple facilities connected to it, which is a very unique, I would say, proposition, where not every facility is handling their own blood banking, identification, and naming and storing databases. And if you look at the cost, even I take roughly 500 USD with the 33% of discount of 165 USD for one facility. I'm just thinking countrywide, of a wide thought, and then do a multiplication for almost 4,000 licensed blood banks. We're still talking about blood banks, not the overall, medicinal product from human origin. We are still not there. Tissues we're not talking about yet. So which goes to more than, approximately 700,000 USDs, which I think will be huge cost. And then, do you have any country licenses that have been processed or worked upon in such case where there is a fair, I would say, win-win situation for the country as well as the standard body? I understand the cost and the maintenance cost and everything, but still from that perspective, I'm just trying to understand. And I hope this is the right forum, because I got a chance to talk to you in this forum right now. We have many Indian implementers out there. Yeah.
It's a very good question, and India, I think, is an exception for in many respects, but not least of all the sheer volume of centers. I mean, I think for United States, I'm going to guess it's about it's maybe 1,000 or something blood banks. It's for a geographically large space, but I think it's about 2/3 bigger than India, but the population is probably
exactly.
But,
Even the 33,000 is probably not
no,
very discounted amount.
no,
I would say.
no. So let me say, my interest is to find the formula, the win-win formula. And I at no point do I contemplate attempting to collect $700,000 dollars. That's not in my plan whatsoever. So I guess if we were a supermarket and you were bulk buying, there would certainly be a discount. So we did reach some accommodation, I believe, with this is before my time, with Brazil, where all of the blood banks in Brazil are signed up through a central body within, I think, the Brazilian health system. So it's, but even at that, the numbers are still at like 300 or 400. But my interest is finding a formula which sustains our activity while minimizes any barrier to adoption. Now, I'd have to say that the real barrier to adoption tends to be the hardware, software, and training. So it's always easier to stay manual or stay with your Excel or stay with your existing system. So the barrier, financial barrier, emerges from the investment or simply the time required to progress with this. Of course, we would say that the benefits in the medium and long term are clear, but nonetheless, my interest would be to find a formula, particularly going through one of the national entities, whether it's at ministry level or agency level, to find that formula. I don't think I'm neither in a position nor I think this is perhaps the right place to discuss that, but I can't imagine a scenario where we couldn't reach an agreement.
Yes, exactly. But I understand, and exactly because of which I just wanted to touch base this point of today's call. But I mean, we can have many follow-up discussions on it. No problem.
Yeah, I think we're at an early stage as well. I see Dr. Shivanand has his hand up there, so I'd like to bring him in. But I think we're at such an early stage. This learning on both sides is necessary. But what I foresee is a formula which is acceptable and which works for us as well, and ultimately facilitates a movement towards standardization in this particular area.
Perfect. Thank you, Eoin. And I think that was my last question. And if there are any, I have even follow-up discussions with Shivanand also coming week. Right. In this week only, I guess. Yes. So yeah. Thank you.
Thank you, Manisha.
Thank you, Manisha. It was an excellent discussion regarding the feasibility of implementation of such facility in India. And I think Dr. Shivanand also had collected some questions from other participants through WhatsApp and other social media platforms. So over to you, Shivanand, if we can quickly rush through the questions.
Yes, sir. Before that, I would just like to introduce Mrs. Manisha Mantri, who just spoke. She is the Scientist Chef and Associate Director at CDAC India. CDAC comes directly under Ministry of Information Technology and under Government of India. So, Madam is one of the key stakeholder in developing the e-Raktakosh platform for blood banks. Thank you, ma'am, for bringing up the valid points in implementing ISBT 128 standard in India.
Yes, just to clarify, I am not part of the core e-Raktakosh team, the blood bank team, but I lead National Resource Center for Electronic Health Record Standards for the country. So wherever standards are there, that's my area of interest and expertise. Thank you.
Thank you, ma'am. Thank you for the clarification. Just I would like to mention a few questions, Ganesh sir, which I received. First question I received was whether this ISBT 128 is regulatory compliable in India according to Indian guidelines.
Okay, so we've looked at this just very initially, and we see that many, but not all of the elements required under the Indian rules for blood labeling are also covered by ISBT 128. So we believe that it ticks most of the boxes. There are some country-specific requirements, but they can be accommodated within the label. By that I mean, if you recall the slide showing the standard format of the label, that format does not exclude additional elements being included and being added in that space as well. The only real constraint in that regard is the physical space available, but additional elements can be accommodated alongside the ISBT 128 standardized components or information elements that were displayed earlier. So that allows, I would hope it would allow a user to adopt and implement ISBT 128, label products, and incorporate those additional requirements.
What topic is it? Carbohydrate blood groups. So needed.
Participants, will you please mute yourself? Thank you.
Dr. Shivanand, does that answer your question?
Yeah. Thank you. And in the chart box also, I can see that color coding of blood groups and labels not required. What I can say is the labeling should be compliable to both ISBT 128 as well as Indian guidelines. Since Indian guidelines mentions it to be mandatory for the color coding labels, so it should be present along with whatever the ISBT 128 guidelines are there. So next question is very simple, but I would like you to highlight the answer again. That do you provide any software or any barcode generator along with ISBT 128 standard?
No, absolutely not. If I can give you a parallel, we all are familiar with Bluetooth in our telephones and our devices and for connecting. And we're confident it's going to work every time that we take our earbuds or whatever and connect to a telephone or a television. Behind Bluetooth is something called the Bluetooth Special Interest Group, not-for-profit, registered in the United States. And that's where they developed the technical standards. The reason I'm saying that is that Bluetooth itself doesn't make available this special interest group, doesn't provide the software nor the hardware. And the same is for ISBT 128. You don't go to Bluetooth and download Bluetooth. It's something that's implemented in your device or your system according to the technical specification. So ISBT 128 is the same. We have, as I say, licensed numerous software vendors and some hardware vendors as well. And it's they that incorporate and program, I suppose, or encode the standard into their systems.
Thank you. The next question is, what I see is you shared that it is around 14 staff who are handling this ICCBA mainly. So it mainly consists of IT professionals and technical experts and management team. So where is the place for the subject experts in this? So I would like to highlight about the technical advisory groups and what is their important role in developing these standards.
So the technical advisory groups, and since I can still share my screen, I'm just going to bring your attention to this. So this is the ISBT128.org website. Note that it's probably going to change a little bit and improve come October. But this is the list of technical advisory groups. Some have a regional focus and or a product focus. If I, for instance, suggest here, this is the Europe, Middle East, and Africa Technical Advisory Group for blood, and in there you can see the list of representatives, typically nominated by representative association, who together should give us all of the necessary perspectives on practices, needs, changes, etc. And all of these people are the experts who will consider those requests, for instance, for product description codes. But the other mandate that the technical advisory groups have is assisting with educational initiatives. So perhaps contributing to or helping with the contents of webinars and instructional booklets, etc. And we are pretty much open to new applications, always preferably from or through association, so that the person is there as a representative of a wider community rather than just an individual. The other people who are there are also observers, and although they're not named here, they're typically coming from companies, software vendors and hardware developers, etc., who clearly have an interest in the technical specification that's coming out of this as well. So I would encourage you to have a look at the committees and perhaps bring back to your national groups or associations a proposal to nominate a representative. That goes to the chair of the group, and it's typically the chair who considers that and incorporates the new members.
Thank you for that clarification. My next question would be, do doctors need additional IT knowledge to implement ISBT 128? So the doubt is, do they need to undergo any additional IT related training to implement ISBT 128 in that standard?
So the unusual mix of medicine and IT exists. We know those figures are around, but I would say they're exceptional. And I would say that the chances of success are increased when you have multidisciplinary team implementing it. By that I mean you have good IT experts alongside the medical experts, because the IT guys don't know the medicine and the medicine guys don't know the IT. So the combination of the two will make for a better implementation process. Not least of all, sort of actually reflects practice and procedures in your blood bank rather than having a process imposed on you due to somehow the constraints or the lack of interest of the vendor in adapting to your facility. So I would recommend that the medical director is knowledgeable of or familiar with the concepts of the standard, but without knowing and having to know the inside out, the technical specifications. Like I've mentioned, our feedback from the software people is typically that our documentation is robust and exactly what they need. But that's written for a very different audience, to the nurse, to the director, to the transfusion technician, etc. And to some extent, we're trying to improve that the information that we provide to them. But it is never to make them experts in the IT. It's simply to make them sufficiently familiar with the concepts of the standard that they understand and they can help and inform the implementation with the IT experts.
Thank you for that clarification. Ganesh sir, that's all from my side. Over to you. And if possible, Asim sir can highlight what are the challenges we come across in implementing ISBT 128 and how we can overcome it.
Thank you, Dr. Shivanand. And as rightly suggested, Asim sir, do you have anything to add to the discussions that we had so far?
Yes, I would only like to add that it is doable, and both the things go hand in hand. The ISBT 128 standards and the software which has to be aligned with ISBT 128. But it's very doable, and we were able to do it. I mean, we didn't find it very difficult to do it. So I'm sure several other people can also do it. And now there is more help available at a local level. So Dr. Shivanand has also joined. So we can possibly help if somebody wants to implement it at his or her blood center.
Yeah, rightly said, sir, because most of us will be eager to go through this transition phase, and there will be challenges definitely, and it is good to have a local resource person at our disposal. So that is again, it was a good initiative from ICCBA, so that we can have one person here locally. And I believe there is no further questions. I cannot see any raised hands. So once again, it was my pleasure to host you in here, and looking forward to meeting you again in person as well as through meetings. And I thank
Great.
Dr. Joy Maman and Dr. Asim Tiwari sir and Shivanand also for this wonderful opportunity and coordinating this coordinated by TMAS. So I thank all the organizers of TMAS also for this, and all the participants who were here till the end. We had a good participation this time. We had around 75 people during the meeting. So
Just
with that, we can wind up.
Ganesh,
And yeah,
if I could just mention, Dr. Shivanand will be becoming a familiar face at national meetings over the coming years. I myself will be at a AATM in Mumbai in November, and
Yeah.
be very happy to meet anybody there who's interested in any further discussion about this.
yeah, good. Great to know that. And with that, I am winding up the session. Have a nice day, Owen, and have a nice evening, everybody.
Thank you very much. Many thanks.
Thank
Bye-bye.
you. Bye-bye.
From TMAS, a sincere thank you to our speaker, Eoin sir, for that extremely informative session. And thank you, Ganesh sir, for chairing the session. We also thank our participants for being with us. We have shared a feedback link in the chat box. Please fill it to and submit it to get the participation certificates. We will soon make the recorded version of this webinar available in the TMAS YouTube channel. Stay tuned to TMAS for further such academic activities and have a great day ahead. Thank you.